Thank you for this generous introduction, and this is definitely the most important talk. This is the first time I'm talking in the lab medicine setting, so this is real test of my, if you like, scientific credibility. And I'm really delighted to be here. I had great conversations with many of the faculty today, and I hope to follow up at dinner later today. So I'll talk about, I try to make this into more of a talk about, not about technology, but about disease, because I think really all technological solutions work best in the context of disease-specific questions, which as laboratory medicine physicians and pathologists, we are able to ask. We are in the best place to ask these questions. So my accidental introduction to amyloidosis started in University College London Hospital. This is the building that was built in, I think, early 19th century, 1906, maybe it was finished. It's a Gothic revival. It's essentially a Victorian hospital. And it has these amazing high-ceiling rooms to make it sort of as airy as possible. People, the wards are these kind of massive high-ceiling spaces. And until possibly 1990 or so, this was still operating as a hospital. Tells you the state of the national health system in the UK. But the building is really stunning work of architecture. On the right here, you see the sort of marble works. The floors are these beautiful colored marbles. And the tower you see in the front of you actually has these arched windows on the top. You are seeing, I don't know whether this arrow will, yeah. And this was the postmortem room. So first day I started there, the chief resident, called senior registrar in the UK system, took me there. And this guy became a world-famous forensic pathologist. He was an autopsy guy. I mean, he knew how to do an autopsy. And he was a forensic pathologist, so he was not interested in the detail, So we started the autopsy. He just pulled the organs out, and spleen went one side, heart on the other, etc. And he looked at the heart. He said, "This is amyloidosis." And then he said, "Okay, I'll show you how Virchow used to do this." So he went and brought this big jar of iodine in a dusty sort of a place that has never been touched, and brought it. And then we cut the heart, and then we were gonna essentially stain the postmortem heart with this iodine. And I'll come to that in a moment. But at that point, I was trying to help him. I knocked the iodine bottle, 2 liters of iodine, onto this beautiful marble floor. Then we, dab the heart onto the iodine on the floor. And then he showed me this characteristic color change associated with iodine. Of course, iodine binds the sugar groups. And then the reason that the term amyloid comes is essentially with iodine stains like starch, because the amyloid background contains glycosaminoglycans and all other sugar groups. That's what you are staining. So this characteristic. So that was the post-mortem diagnosis of amyloidosis. And that comes from Virchow. So that's what I learned, and many years later we converted this building into a medical school, and that tower became the multimedia learning center simulation, and then the iodine stain was still there on this on this marble floor. So the amyloidosis is caused by sort of extracellular deposition of proteins in an abnormal physical format, is often referred as beta-pleated sheet. This is a sort of a folding pattern for proteins. And it may have a localized and systemic disease, and we'll see examples of those. So most common presentations are in systemic disease, of course, the kidneys, the heart, and the nerves. Those are the 3 big organs that are, that makes this clinically important. But of course, localized amyloidosis could present with mass. The diagnosis really depends on the clinical presentation, but most of these advanced cases would present with either systemic symptoms, some skin changes, and the features of renal or cardiac failure. The diagnosis is done by histology. There is no other way of diagnosing. You have to show these abnormal proteins in the tissues, and that is done under the microscope. There are ways to screen for this. So if you are suspicious but you don't want to go and biopsy the kidney, you can do screening tests, and most commonly used is the subcutaneous aspirates. Maybe you use it here. This is you stick a needle into the subcutaneous tissue and pull up a specimen and stain with the congruent stain and try to see whether the patient has amyloidosis. But in these days, because target organ biopsies are relatively easy and low morbidity, most frequently we see them in cardiac biopsies or renal biopsies. Sometimes nerve biopsies or other organ biopsies gives you the diagnosis. So the histological, the diagnosis is done on histology, and because of this beta-pleated sheet structure, you can stain the amyloid using several dyes, which specifically binds to the structure of amyloid. And the congruent is, of course, the very well-established dye that has been used extensively, and that's what we use in our clinical practice. But there are other ways, probably with similar specificity but less sensitivity, that one could use. And some people use electron microscopy. I'm not a fan of it because of the limited sampling available for electron microscopic analysis. Now, there are many proteins, over 30 and counting, that cause amyloidosis. Here are the list of those that cause systemic amyloidosis, and the most frequent of those are well recognized. AL amyloidosis caused by immunoglobulin deposition, ATTR deposition by transthyretin, and AA amyloidosis caused by deposition of serum amyloid associated protein, which is a acute phase reactant. But the list is long, and there are quite a few other similar proteins in the differential diagnosis. Now, the way that think about amyloidosis, it is a process where normal physiological mechanism is exaggerated. Once proteins are produced by a ribosome, they have a tendency to fold into different structures, and these are managed by chaperones, which take the protein and fold it into the necessary functional complex that could be used for cellular processes. But during this process, there are many intermediate forms, and some of them may take an amyloid form. So this is a balance between different ways of folding, and then you hope that the physiologically relevant, unharmful form will dominate. And this is the case for vast majority of the cellular proteins. However, in amyloidosis, a number of factors are altered, which may push the balance to the left here for deposition of amyloid fibrils. And these include intrinsic proteins or features of the protein, such as transthyretin is amyloidogenic, so it tends to fold more on this side. Excess production, if you have a lot of the protein, although your amyloid fractionally may be less, it may be clinically important because you have such a high level of amyloid that's folding into this. Or variant proteins, which has intrinsic ability to fold, mutations caused by in the immunoglobulin genes, for example. So all of these push the balance this way, and you can imagine treatment should be therefore to push the balance the other way, and there are different ways of doing this. Now, the examples of these, excess production, for example, AA amyloidosis is an example of excess production. You have a huge amount of AA amyloid, which normally the amyloid folding would be very minimal, clinically relevant. But if you have the balance is shifted, you have 5% of it being deposited amyloid, that could be significant. And the variant, of course, transthyretin is well recognized. Mutations in transthyretin genes leads to early presentation of amyloidosis. But obviously, there are other factors which we don't know, possibly genetic background and what the microenvironment is, etc., because not everybody has the same phenotype with the same mutation, for example. Now, the critical thing about amyloidosis is that it is treatable, but at a high cost. For example, for AL amyloidosis, the standard treatment is essentially high-dose chemotherapy with bone marrow transplantation. So if you get it wrong, the type, basically the patient goes through a $500,000 process that has 5% mortality. So it is really a critical decision. In a hereditary ATTR amyloidosis, you may get a double transplant, one for your heart, one for your liver to essentially it's gene therapy. You are changing the liver producing the transthyretin into a transthyretin that is not mutated. So the real decisions are huge. It is as high risk as any cancer treatment, and the risk for the patient is also similar to cancer. These patients do not live the average life would be like for most of the series, 4 years or so after diagnosis. So they are really deadly diseases and require treatment, but the diagnosis also, has been problematic. So many practices use clinical parameters. If you have amyloid and increased immunoglobulins, they call it AL and transplant the patient. But the accuracy of that has been challenged by many papers. So people started using immunohistochemistry-based based assays, and they have been shown to be very flawed. There are many reasons for this, and laboratory medicine physicians understand them very well. Essentially, these are individual tests. If you develop an immunohistochemistry test, you are developing a kappa test, lambda test. They are independent tests. So the result of kappa does not affect the result of lambda. So it's not like a multiplex test that you are competing with each other. But we interpreted these things as a single test. So we look at, is kappa more than lambda, then decide that the patient has lambda or TTR. So there is a fundamental failure to understand the flow in the test development and validation processes in immunohistochemistry, because you cannot interpret this kappa is positive, it is positive. Lambda being positive doesn't make kappa less positive. But that's kind of how we have been doing it, and that's why there are so many false diagnoses by immunohistochemistry, because you cannot cross-validate. Is it positive or negative? It's an independent event from the other one. Because they are independent assays. So you don't manage thyroglobulin levels based on the PSA levels. They are two independent measurements. If this is one, so this is the similar thinking, that they are independent assays, but we interpret it as if they were linked to each other. So that's really the fundamental flaw in the diagnosis. Therefore, really, this was a big challenge, and we had great difficulties at Mayo Clinic, where there's a big amyloid population, and I was in charge of immunohistochemistry, and I didn't know how to address this. Here's an example of how this looks. This is a cardiac biopsy. Immunohistochemistry SAP has been done, and SAP is the generic protein expressed by all amyloids, and you can see strong expression of SAP. And then if you look at our assay at that point, is it lambda or is it TTR? According to the existing wisdom, I would call this an AL lambda, because lambda is darker than TTR, but they are two independent assays. So it's positive for both, essentially. That's the reality. But these, traditionally have been interpreted lambda, and this patient, if they would get a stem cell transplant, if you call it lambda, it has cardiac amyloidosis. That's the only chance of survival for this patient. So to address this, we thought, okay, we turn into a different technology which would give us the constituents of the proteins, and that was shotgun proteomics. What we used essentially was a bottom-up approach, is digesting the proteins into peptides and really identifying each peptide that's present in the amyloid plaque. The advantage of this technology is it's applicable to any matrix. Matrix essentially could be used for blood, anything else you want, paraffin-embedded tissue, fresh tissue, cells, so it's widely applicable. The instrumentation is extremely accurate. The accuracy of the measurements are unmatched in the medical world. It is available both on the analytical side, and there are really very good post-analytical tools. There are no real reagent requirements, so you don't need to develop anything. You can just run the assay and get results. It gives you at least some semi-quantitative information, and you can even pick up post-translational modifications in addition to the native peptide. There has been many challenges to translate these technologies into clinical practice, but most of it essentially is legacy and organizational challenges. Who owns the technology? How do you convince your hospital to pay for this? Where do you create the resources? How do you identify how you get buy-in from your clinicians and your pathologists and physicians, really, that they use this technology, take it as an opportunity. Sometimes, of course, if the matrix is very complex, such as the serum, it may be difficult to pick up low abundance proteins, and that may be an issue for some of the cellular proteins and, of course, serum proteins. It's expensive to set up. You start $1 million and up for a laboratory. It's only semi-quantitative. You can't really, the way that we have used it is not really purely quantitative, and there are some post-analytical challenges, and I'll describe some of these in a moment. So let me skip that. So when we tried to bring this up, we had to really rethink the whole process because this has never been done in a clinical lab. And Jason Thies wrote a very detailed paper of the quality systems we have to put together to make sure that what we are doing was acceptable as a clinical practice tool. And this is this kind of the bare bones of the fishbone diagram he produced. Actually, it was more like a whale diagram when we had, we had so many issues to address. And you really one has to consider all of these to be able to have a robust system and then decide how we are going to control each step and what kind of risk we are going to, because every decision we make about our process introduces some risk of getting something wrong. So we were very obsessive with this because of the way it was such a novel technology, and we didn't want to be burned by having a hole in our quality systems that may lead to a false positive, false negative, or wrong diagnosis. But this is detailed in the paper he wrote, and if you are interested in this, you may want to look at that. So what we are doing, essentially taking tissue, we often use microdissection, take the proteins out and chew them into peptides, cut them into peptides using trypsin. Using an HPLC, we stack them, we ionize them, and then spray into the mass spectrometry, measure the parent mass of each peptide, and then we fragment those peptides, measure again the fragment ions, and then that sort of mass of data is then computed into a meaningful amino acid sequence. Essentially, we are sequencing the peptide by using computational tools, physically fragmenting the peptides into fragments and trying to predict what the actual amino acid sequence of the peptide was. And this is kind of, I'm not very savvy on exactly what mass spectrometry does, although I have used it extensively. This is how I understand it, and I hope it helps you. So we start with a protein. We cut it into peptides, and trypsin cuts each protein at a certain residue, identical in each case, very similar to DNA restriction enzymes. And then we separate them using chromatography, select the abundant peptides, and then selected peptide then is imparted energy to fragment it, and then fragments are measured. So it's almost like having a peptide. You cut one amino acid, weigh it again. You cut, weigh it again. You cut, weigh it again. From that, you can calculate what the sequence was, because each amino acid has a different mass. Of course, the way that this fragments is not by amino acid, but the different fragmentation, because it really destroys the thing. So it is much more complex than that, but that's how I try to think about it. Now, once you, of course, develop all that mathematical information about the fragmentation pattern, you have to assign a meaning. And this is done by using bioinformatic algorithms, which interrogates the fragment information against a theoretical fragmentation based on a reference database. So that is really the critical part of that. That's sometimes a weakness. Your detection ability, it really heavily relies on how good your database is. And your database should be specific to your disease question. If your database is, if you use the human genome version 18 or whatever as your database, protein database, there are certain gaps that may not be addressed with that in a certain clinical situation. And this widely applies to amyloidosis because of the variant proteins. So amyloidosis has all these mutated TTR proteins. You may not see them if they are not included in the database. You may not be able to see all the mutated immunoglobulin genes that are present in AL amyloidosis, the most common type of amyloidosis. So working with one of our bioinformaticians, we really developed a sophisticated bioinformatic pipeline, which, we put all the disease-specific protein phenotypes we know for the disease into this database. So beyond what's available in the public databases, we created essentially our database. Also, we established a different discovery pipeline that could interrogate the data without knowledge of the database. So those were, this beyond me, and these were developed by Surendra Dasari, our bioinformatician, in a very sophisticated way. And that helps us actually increase accurate identification of peptides in this disease state. This database may be useless for another question that you may ask. This is really specifically developed for amyloidosis. So we studied, the key to our success was actually to simplify the input into the mass spectrometry. And this has been the main downfall. What we did was essentially use microdissection to really pick up the amyloids. And we go to we used extreme microdissection. These are really tiny fragments. And we are here, as you are seeing a glomeruli, that's about 100 microns across. So that's about, 10,000 square microns. And it's being microdissected. And this is a slides upside down. It's going into a tube. And that's what we use for a single run. So that is really what you require to get a pretty comprehensive result. And that was the key to our success, because we simplified the question for both the mass spectrometry. We are putting a relatively pure sample, but also analytically, because you don't have so much information. So really, without that, I think this would not be possible if we try to do. People have done this in the past. Technology was available. If you put the whole kidney in there, for example, you are going to get so much information, it's going to be meaningless. So this was really the major strength of our approach, that we can use microdissection, and the microdissection technology at that point had come to a point that we could have this kind of precision. The other good thing about, of course, is that the problem with the microdissection is it's often difficult to see what you microdissect because you don't have a cover slip. Amyloid is such a great fluorescent stuff, you can easily see that. So that's really the other stuff. When you stay with Congo Red, these things light up. So it's very easy to microdissect. That was the other advantage. So, and this is what when you put the sample, this is what you get. Here is that kidney biopsy. There are 4 glomeruli on top here, 1, 2, 3, 4. And on the left, proteins we identified in relative abundance. It's a very simple morphological presentation. There is no real magic. And the numbers here are the spectral counts, so how many peptides we have, peptide spectra we have identified in a given protein. So it gives you a relative proportion, and this is heavily dependent on how big your protein is. So you might have a tiny protein here. If you have, one peptide 40 times is different than huge protein, which you have 40 different peptides. But still, it gives you a relative sense. And these are the list of proteins we have identified in that glomeruli. First of all, what you are seeing is that there are a couple of proteins that are well described to be present in every amyloid. These are possibly the chaperones that lead to abnormal folding, ApoE and SAP. Next is we are seeing immunoglobulin lambda constant region, and that tells us that this is AL lambda amyloidosis. Additionally, we have a variable region. Variable region, of course, unique to the patient, unique to the plasma cell clone, so that is clonal amyloid. So that tells us that not only we have lambda, but it's a clonal lambda light chain. Further down here, you see, for example, clustering, a common component. It's a well-recognized chaperone, possibly involved in amyloidogenesis. So there are other information that's available. And this is the cardiac case we had, I just showed you, which was diagnosed as AL lambda. And here is the list. You can tell me whether this is AL lambda or transthyretin. Not very challenging. So this is as simple as this becomes. From where we were trying to interpret that mushy immunohistochemistry the top hit here is transthyretin. There is no evidence of lambda in the top 10 proteins, so it's no-brainer. And we are in heart. You can see that we have myosin, actin, desmin. We have SAP, part of every amyloid, ApoE, and bang, our diagnostic is transthyretin. So that's basically, once I had this data, there was no going back. This is so far superior to what I had by immunohistochemistry. That was it. So we basically used a sort of a very crude way of validating this. We picked up 50 cases diagnosed based on gold standard criteria, not by immunohistochemistry, because it's really a bad method. That would be clinical criteria. The patient we were sure that they had the right type of amyloid, and typed it and showed that this was basically 100% specific and sensitive. We picked up every case accurately, and 5 of these were misdiagnosed by immunohistochemistry. And to give you a sense of the accuracy of this, this figure that Jason, this is not, in real life it's never this clean, but he's showing here us the cases. On top are the different types of amyloid. On the left are the proteins. So if you look at the first, I know it's a small slide, but ApoE is the top hit, SAP, so those are the common amyloids. So every case has these. And then we also see ApoE4, which is frequently present, but not in every case. And then you start getting the specific signals And virtually all of these specific signals are not shared by other types of amyloids. So this is what you want from, so it is extremely powerful in picking up the specific amyloid signal. And it's a very reliable method. The other thing we did actually was to look at this. I told you about this fat aspirate being a screening method. We said, okay, can we just stick the needle to the patient, take the fat aspirate, don't do morphology, just put it in the digest and put it in the mass spectrometer. Can we tell whether it's amyloid or not? Can we tell the type? And this is actually amyloid in the fat aspirate. This is how it looks, and this is the smear being done by the cytologist, and it's congruent positive. So when we did this, first of all, what we saw that we can really pretty well pick up a proteome that we can make the call of amyloidosis. And here you're seeing the amyloid-specific peptides, ApoE. So these are the control samples, SAP, and APO is not present. And then, for example, ApoA1 is present in normal fat. So this is this is what's important to understand your matrix. So if you are looking at the fat, ApoA1 is present. If you are looking at the heart, it may not be present. So you have to really think about these issues when you are developing the assay. So ApoA1 is both present in the congruent negative and positive cases, but ApoA4, ApoE, and SAP seems to be specific for amyloid. And interestingly, of course, when we looked at compared the results with the histology, there were patients that were there was only one case there was false positive. This is a blind assay, so the patient had no amyloidosis, but a myeloma patient with very high level of kappa. So we called it kappa based on the proteome, but actually it was coming from the serum. But the most interesting thing was we don't use this as a clinical tool. Of course, this is at the moment I'm talking about research. But what most interesting was that there were the cases that we know the patient has systemic amyloidosis, but fat aspirate on morphology was negative. So we couldn't see the amyloid, but the patient had documented amyloidosis elsewhere, and half of those patients had signature of amyloidosis. So in some ways, this told us that the mass spectrometer had possibly higher sensitivity to diagnose amyloidosis. We have not translated this. This is a bigger challenge, to change congruent as the gold standard, making into Proteomics. It is a big undertaking. We haven't done that, but we use this now as a screening tool. So if we get this is an indication to go and do a target biopsy for the heart or kidney or whatever, because we may not have it in the morphology of the in the fat aspirate, but we have the proteome of amyloidosis. That's an indication for the patient to have a more aggressive biopsy. By itself, I can use it, but I think it will take a lot of other validation and a larger number of cases to be able to convince, to change medical practice from a microscopy-based thing into a comprehensive proteome-based diagnosis. But it is doable, but it will require energy and resources that at the moment I do not have. The other question we ask, of course, we have all these variant proteins causing amyloidosis. Can we see them? As we built our database to become more sophisticated, here are the TTR variants on the left. You can see that vast majority of the TTR variants we can actually identify. So these are hereditary mutations patients have. So this became pretty much standard effort. We get a cardiac biopsy, we do the mass spectrometry, we see it's TTR, but we also say basically we are seeing this variant peptides, you better go and sequence the gene. We don't do genetic diagnosis yet at the protein level, but in many instances, virtually every case we called as a mutation was confirmed by the genetic analysis, and this is some of the data is being shown. So it is, it is so powerful. In some ways, I think it may be specificity and sensitivity may be similar to sequencing assays because of the instrumentation we use, the accuracy of that instrumentation we use. So it is extremely powerful. You can imagine this kind of technology being broadly applied to cancer mutations and everything else. So it's extremely important. So with this tool, of course, then we can ask more interesting questions. We have thousands of these proteomes, and then you get a case that you don't know what, all our conventional amyloid stuff was negative. And this was a kidney biopsy from a Hispanic patient, which was involved with amyloidosis. We did our microdissection, We looked at it, really there's nothing there that we have ApoE that tells us amyloid, but in this list there is nothing that I can recognize as causing amyloid, so this was inconclusive. But I noticed that sort of a protein, this is eyeballing, after seeing hundreds of thousands of these, what is that? That's LEC2. Never before described in this context. And then same day we get a liver biopsy, has this very unusual globular deposits in the portal tract, congruent positive, immunohistochemistry negative, and then we microdissected that. Bang, it's LEC2, it was on the same day of these biopsies. And then it became apparent that, this may be a new type of amyloidosis. We went and looked back into our database. We had 7 other cases we called inconclusive, and all of them had this LEC2 peptides, but it wasn't seen in any other tissue or context. So it's, if you have 5,000 cases, you can ask this question, and you immediately know that it's specific. You are seeing a new type of amyloid. This was confirmed by immunohistochemistry, both in the kidney and the liver, so we developed this to make sure that we have another measurement. And this emerged as one of the most common amyloidosis types in the Hispanic population. And can you believe that we have never actually noticed this? These patients are around. So this is really after AL and TTR amyloidosis. It is maybe in the Hispanic population, maybe 10% of the amyloidosis is LEC2. And I don't know how these patients were diagnosed, and without an unbiased method like this, there's no way of identifying. And these patients, some of these patients have received transplants and all this kind of stuff, and some of these we published, and this was a major recognition. It is an indolent disorder, possibly doesn't require treatment, but the issue is, of course, it overlaps with so many other amyloidoses. You may misdiagnose and treat the patient. So it marked Hispanic bias, but also seen in other ethnic groups. We had some Punjabis, Middle Eastern, Israelis, Native Americans have this disorder. So everything suggests a hereditary background, but we and others have sequenced the LEC2 gene and promoters, etc. We did not identify a pattern, so we don't know the etiology. Really, the main issue is slowly progressive chronic disease. The protein itself appears to be a chemokine. It has a number of biological features. There are some association with rheumatoid arthritis. It has been proposed as a marker for hepatocellular carcinoma in the serum. In our cases, we saw some overexpression by inside hybridization in the liver. Maybe we thought this is more like AI type amyloidosis where you have excess production, but that hasn't been formally documented. And no mutations and no serum studies have been done. So, and without this kind of technology, so I'm wondering how many other diseases that we don't know, we assign other meaning or other diagnosis that, because we see what we know. The advantage of mass spectrometry proteomics is that you see everything. And whether you can assign meaning is the challenge there. Here is another anecdote. This was actually a male patient. The patient presented with these abdominal lumps you are seeing here. This was the main complaint. So there was no real features of systemic amyloidosis. But the patient also had a proteinuria of undescribed. So there is some suggestion that it may be related to amyloidosis. So this was biopsied and showed this abdominal fat with a lot of amyloid. We microdissected that, and this is how it looked. It's our list. You go through the proteins. Oh, looks like amyloid, and there's one that's starred there. Insulin. So, wow, what's happening here? This is insulin in abdominal fat. What does that mean? And so I rang the surgeon and asked whether the patient was diabetic, and he said yes. So I got the immunohistochemistry. We all have it in the lab. Insulin was positive. And this turns out to be iatrogenic insulin amyloidosis. It is a common but under-recognized complication of insulin-dependent diabetes. So the patient's essentially injecting insulin to the abdomen, And as they injected the same area, apparently, you have, I think in the literature it's called lipodystrophy. They get this kind of change, but essentially it's amyloid deposition. And the lump becomes nicer, so you can grab it and keep injecting into it, and it gets bigger and bigger. So, and that's most of the cases we have seen is being like repeated injection in the same area. And then they start insulin resistance because it doesn't get absorbed. So they increase the insulin dose, injecting in the same thing. And when the physician says, no, inject somewhere else, then they get hypoglycemia. You can imagine how, how this works. So, and it is quite common. I've seen, several, maybe around 100 of these cases. And then if you look at the peptides that you are detecting in this is very interesting because iatrogenic, native insulin is a complex protein, it's cleaved, etc. There are different peptides. Iatrogenic insulin is consisting of this insulin A and B chains that are covalently linked. And what you see in the mass spectrometry is just this iatrogenic one. You don't see, of course, C peptide and the leader peptide, etc., because it's not cellular. So. And then actually some of these insulins have modifications at the tail end that helps to increase the insulin half-life so that you can have it, metabolism slows down, so you can have it longer life insulin. And really some of the cases we can tell which pharmaceutical company produced insulin based on that. Here's another case. This was an interesting case. The patient was an HIV positive patient. Developed this triple class viral resistance profile, and treated with this new generation drug, which I had no knowledge of. Commercial name is Fusion, and responded. But the patient then developed these large indurated masses at the injection site. Here are some pictures from another case, and it was amyloid. We microdissected and put it, another one of those puzzles. We have all the amyloid signals, but nothing else. Jason Thie is our chief technologist there. Okay, he went to Wikipedia and looked at the drug. And drug is actually a viral analog peptide. So this is a viral mimic. It's not a native peptide. It really mimics a viral protein and prevents HIV binding to CD4 cells. So he went to the pharmacy, got one, and see whether we can see this peptide in the mass spec. We could. And then we got the sequence of that peptide, added into our database. Bang, it was there. So it's a single peptide. And this is the coverage. This is the length of the peptide. That's what you are seeing. So this was a database problem, post-analytical problem. We had the diagnosis there, but we couldn't see it because our database is human. We don't have viral peptides in there. So again, to get an example of how you have to think carefully about your post-analytical steps, and this turns out to be a novel type of amyloidosis, which is caused by Fusion. The other interesting story is the beta-2 microglobulin amyloidosis. So this is a well-recognized complication of long-term dialysis, where especially in the older filter systems, the patients have increased beta-2 microglobulin levels due to the inefficiencies or failure of the filter system in the peripheral blood. So the more dialysis you had, the more beta-2 microglobulin in the serum. And these patients eventually get amyloidosis, especially in joints and tendons and that kind of thing. But no real hereditary forms have been developed, and this is a decrease with the new dialysis machines. It's not a problem, so this is a decreasing process. I have a French collaborator, a brilliant geneticist, Sophie Vallée, who actually identifies these families of amyloidosis and occasionally sends me, when she can't solve the problem of what kind of amyloidosis the patient has, sends us a specimen. So she sent us the specimen from this family, which had 4 members that were affected. And really, I got scraps of tissue, and then when we put it together, it turned out that it was beta-2 microglobulin. And I sent her an email, is this patient a transplant? She said, no transplant, this is a familial amyloidosis. And they sequenced the gene and identified this variant, which they did a lot of elegant biology work showing that variant was amyloidogenic, which was published as a case report in New England Journal of Medicine. But it started with a simple, humble observation from the mass spectrometry-based proteomics identifying beta-2 microglobulin as the cause of it. And then she keeps on sending these families. Here's another one that we did recently. This is again a family that has multiple members in black that's affected. And you see here the SAP scans. This is a scan they do in the UK very successfully. The patients have both liver and spleen, but also bilateral kidney involvement. This, I think, 2 different patients are from the same family, and they have this kind of very specific pattern. And this case, I looked at this, and really I couldn't recognize any known amyloidogenic proteins, but I saw apolipoprotein C3, which has never been associated with amyloidosis. And it took some convincing to get Dr. Valet to believe me that this could be a new type of amyloidosis. She agreed finally to sequence the patient and identify a variant, which has not been previously described. And this variant essentially changes the biology of apolipoprotein C3. These patients have very low, I guess, LDL and high HDL, very cardioprotective phenotype, just opposite of mine. And but the variant, unfortunately, they don't get heart disease, but they get kidney disease because of amyloidosis. So variant is very amyloidogenic, and they did some very elegant in vitro assays, show that actually that was the case. It's a beautiful paper if you want to look at that. So again, this came from the assay. Without this, it's really, there are so many this kind of variants, etc. you can identify in these genes that you can never, without phenotype, you can never assign a meaning to the genetic findings. So that is really the power of the technology. We are really looking at the phenotype. What is causing the disease? The interesting thing, of course, we can also pick up here, for example, only the variant protein was being deposited. So on the lower end here, what we are seeing is only the variant protein present, but we didn't see the native protein present because native is not amyloidogenic. So this is really a problem of the variant protein. So, if you look at the global picture of amyloidosis now, it is a major, our understanding of amyloidosis has dramatically changed with the application of mass spectrometry. A third of the cases are TTR associated. Perhaps 60% or so are AL amyloidosis, but there are many, many pitfalls if you use a limited technology that may lead to a wrong diagnosis. Most important of these, of course, LEG2 amyloidosis that has emerged as one of the most common types of amyloidosis in Northern America, and that was not previously recognized. And then all these different hereditary variants. There are several others in the pipeline that we have identified on the protein level, and we need to convince our collaborators to believe that this is real, and they can go and do the sequencing studies and in vitro studies. But this is a constant discovery pipeline for new biological understanding of the systemic amyloidosis. Now, if you look at the history of amyloidosis, this started with the chemical dyes, Congo-red, iodine first, Congo-red second. And that was really identifying amyloid. In the 60s, people realized clinical patterns. There was, if you look at the 1966, Robbins, you'll see that there's a primary amyloidosis, which is what we know as AL amyloidosis. There's secondary amyloidosis, what we know as AA amyloidosis. There's age-related amyloidosis, and then there are hereditary amyloidosis. Those were the clinical patterns. And we assigned, primary meaning to this by using immunoassays. AL became primary became AL, secondary AA, etc. But now with the advent of mass spectrometry, of course, we have over 30, 35 different types of amyloidosis, which has changed the way we understand disease, taught us the risks we were taking by limited immune-based assays in this context. And then there are many, there are, and really improve the clinical care of these patients. So it is really, this is an anecdote about these comprehensive phenotyping tools, how they could be extremely useful in the context of clinical practice. And as laboratory physicians, our role is really to bring these technologies into into niche areas. If we can identify, that would improve patient care. And that's really our role. It's not going to be done by the scientists who develop these technologies. It's not going to be done by the physicians who trust our judgment that we would provide the best diagnostic information. It will have to be done with us, and it will start people like us sitting in this room thinking about the problems and applying the technology with its pitfalls and strengths into given clinical questions. So I have to acknowledge two groups of people. First of all, the Mayo Clinic group who worked with me in this one has been extremely instrumental. Julie really started our effort with the microdissection and the clinical annotation. Jason was our mass spectrometry master who kept the instrumentation going. Surendra did many of the bioinformatics. Paul has been a great colleague of mine dealing with the clinical side of in the pathology, and then on the Hemong side, is Angela and Dr. Gertz have been instrumental implementation of this test. At Mayo, we are working with our postdoc Stella Ritorta. Madalena is our pathologist. And then Dean Carlo is one of the laboratory medicine folks. Ron Hendrickson runs the Proteomics core, and Heather and all our myeloma physicians interested in this process. And I will stop here and take your questions. Thank you for listening so far.
We have time for a few questions if anybody has them. Let me start. You started out by saying that mass spec is accurate and it's infallible and it's the most accurate technology on the face of the planet. But we know that shotgun proteomics has a false discovery rate and it does misidentify things. And so in the clinical lab, in our clinical lab, we've really focused on targeted approaches. Have you looked at targeted approaches and looked specifically for the peptides that you know should be there and compared the more precise targeted methods to your more semi-quantitative shotgun methods?
Yeah, we had a half-hearted effort look at so once we had about 1,000 cases, we looked at the best peptides from the mass spectrometry and developed standard MRM-like approaches with heavy peptides and tried to develop an assay. We selected maybe one or two, I cannot quite remember detail now, peptide from each protein that we had identified. The issue was, the danger was that we developed this algorithm that, if it's, because, there is some relative assessment in each case. So because there's always a bit of a background depending on how much you are serum, in lambda case we'll have a few kappas and that kind of thing. So we developed this algorithm. You start with that, if you pick up kappa, you go to this. But at the end, of course, those kind of approaches end up somewhere as a diagnostic and sometimes it's wrong. It was difficult to know where to stop and call it inconclusive. Because we selected limited peptides, some cases we didn't pick up anything, whereas we can pick up with shotgun because there was a variant peptide, there was an incomplete digestion that we can pick up by the search algorithm, but is not visible by the ideal trypsin cut. So it may be done, but it will require a very comprehensive rethinking of how those targets are selected. We basically selected the best flying peptides and then worked on those. But that was not sufficient enough to have the same sensitivity we had. And then we ended up, because we were not seeing LEC2, you'll never see it. So that case could have been assigned something else by accident. Because if you have a bit of lambda, so you just go over the threshold, you may assign that. Whereas in this one, we are seeing a big picture. You are seeing all the C, essentially, you can pick up, It is very powerful. I feel uncomfortable with the targeted because I'm not seeing, I'm worried that I'm not seeing the elephant in the room. This is, it is, but it may be addressed but it will require really careful thinking, understanding all the pitfalls from the pre-analytical side and the peptide, the amyloid structure. And one may need to look at like 10,000 cases, analyze them carefully, pick up all the patterns that's identified and develop targets that's based on that. Now it may be possible because we know also we identified all these other rare types of amyloidosis, so those peptides are also available. So maybe it may be doable. But then if you are going after 100 peptides, 200 peptides, why not do shotgun? And because quantitation is not, it's all going to be relative. Your matrix is not standard. It's never going to be standard. So you start with an unknown quantity of tissue from from unknown amount of amyloid.
But following up on that just a little bit. So when you're looking at this long list of numbers, you, the pathologist, are interpreting those numbers, just like looking at an IHC stain.
Right.
You're interpreting the relative numbers
Right.
versus others. So there is some subjectivity to it.
Yes, and also, we didn't really, yes, there is subjectivity, and we also bring our clinical judgment. We would never call something that doesn't fit into the clinical picture. We would call it carefully and suggest additional testing. We may go and do bone marrow biopsy or whatever, and go back and try to improve our accuracy in this. So we have done things like that. We think, for example, there was a case of renal amyloidosis that was heavy chain variable region only. So we had a hint that the patient had immunoglobulin-associated amyloidosis, but because variable regions are heavily mutated, we were unable to call it confidently. I'm seeing 5 peptides of a fragment of a variable heavy chain, but we are not seeing the rest because of the mutations. So for that case, for example, we went back and sequenced the immunoglobulin gene from the plasma cells patient and then fed that back into the database and showed that it was, again, this was done under research. Of course, it was not, but we kind of, that gives a comment. So, we use extreme judgment on all of this. Clinical judgment it was always part of it. If you wanted more analytical black and white, I think you really have to think more like more clinical chemistry assay, which may be challenging. Certain things I know by looking at it's going to be fibrinogen alpha, hereditary amyloidosis. I mean, I look at the kidney, I know it is going to be, or ApoA4. Those things I kind of know now. I've seen so many of these. And then the mass spec, so we bring all of that information, and we always report in the context of medical opinion, not as standalone tests with a bottom line saying that this is the measurement.
I think it's important. I think you're practicing medicine with a mass spectrometer. Kelly.
So I had a question about with your HIV patient and the fusion peptide. There you had an amyloidogenic peptide that wasn't in your database, but you had a good target to go after because you had a hypothesis that this was causing it. I was curious if you actually looked back at the mass spec data. Could you look at that data and actually find an abundant peptide that you knew that you weren't identifying? So is there a way for us to look and see if there's something in there that we're not picking up to give us that information that would say that our database is inadequate and maybe we have to do some a priori sequencing or something like that to really find that novel potential?
I think that's a very good question. I think the data is there, but we have never properly analyzed that. We database, we always ask specific questions backwards, but not really. The variable region information, we were talking today, is there, but we are not seeing it. I mean, if the AL amyloid, as I showed, there's one variable region, tiny one peptide is identified, and there are at least 6 other peptides from that variable region in that sample, but we are not seeing them because we don't know the sequence, and those may be recognizable by not data by search, but there may be some other analytical ways of looking at that mass spec data, identifying those unique peaks which may indicate amyloid, that different variable region. And that will be very important because variable region is the pathogenic part of the lesion. And in some instances, we just have variable region deposition. So by accident, that variable region is not covered by the databases. You're not going to see it. And, my worry is sometimes there are things like, ApoA4 amyloidosis, especially, ApoA4, it's now kind of accepted that there is an innate, ApoA4 amyloidosis, but I don't know whether some of those ApoA4 cases has a lambda variable region being deposited, but we are not seeing it, and we think then ApoA4 is the cause. I mean, there is a clinical phenotype, that's why it gives me confidence that ApoA4 is a real amyloidosis, but we haven't quite ruled out. So, there are things like this where certain proteins are both chaperones or also primary causes of amyloidosis. So that negotiation is very hard. You know, is there an elephant in the room I'm not seeing here? There's a big, like a lambda light chain, and I'm assigning is an APOA1, for example, is one of them. Those are, they're still unresolved, you know, and so, you know, for those APOA4, which could be shared by different amyloidosis, but themselves could cause primary amyloidosis, you know, we have been very careful how we phrase those reports and make sure that the patients are investigated for an underlying ALM, because that's the one that we are going to miss because of the variable region, you know, and it's the most common one.
Let's have one more short question.
Thanks for a great talk. My question is, in the interest of doing as many omics as possible in one assay, as the cost of sequencing goes down, do you envision a time when you would perform exome or whole genome sequencing for a patient, and either for the purpose of providing a customized database or to follow up on possible variants?
Yeah, I mean, that's a very good question. I think, you know, assuming that at some point we'll all have our genome sequenced and available in database, so this search would be done against our own variants, etc., and that would be very powerful. But of course, these acquired variants will always be a problem. You know, hereditary ones would be covered, but you know, most frequent is AL amyloidosis, 70% of the cases, and that is the mutations are acquired during the plasma cell differentiation, so that won't be reflected in the germline, and that is a challenge. So analytical, you know, bioinformatic tools to identify those variant peptides would be very helpful. Or we have to go and, you know, for it's like an institution like Sloan Kettering, what we are doing is essentially sequencing the plasma cells from the patient, showing that it's being deposited. I mean, but we can do it because it's a niche institution with a specific mission. But it won't be possible to do that in a more, you know, general practice. Yeah, I mean, so that would be great. But so then do we sequence every plasma cell, so not only the genome but also all the plasma cell to be able to say that it is extensively covered? I don't know. I mean, the interesting thing is this variable region is an important issue, and our immunoassays that will apply to free light chain, etc. Really, they are all constant region, and in amyloidosis, we know that the constant region is frayed. So if you are using an assay to pick the constant region, and we have examples of cases, we just have the variable region, no constant region. And the assay is maybe grossly underestimating the amount of clonal protein in the serum, or, you know, it could be very minor. It may be below the threshold of free light chain assay because we are using constant region. But actually, the patient may be floating in the variable region fragment. And this happens, you know, there are different immunoglobulin deposition disorders. There is one called crystal storing histiocytosis. I don't know whether anyone has heard of this. Crystal storing histiocytosis is essentially all variable regions. So it is being digested and then deposited as variable regions. So if you stay with, you know, use immunoassays, you're not going to see it, but you see it by mass spectrometry as long as you have the coverage of that variable region. So this is an issue, and we did some urine studies actually at Mayo. So you would pick up, you know, a couple of very small amount of the clone in the urine. If you look with just look at the kappa or immunoassay, but when we did mass spectrometry, knowing the sequence, plasma cell sequence, so that we knew exactly what the peptides were, there was huge amount of the variable region in the urine of this patient with renal amyloidosis. And that was not visible by immunofixation, you know, and other methods, because constant region was digested away. So it is, you know, it is a big issue, and that has to be, you know, considered when dealing with AL amyloidosis. AL amyloidosis could come and bite you any moment, even if you have the most sophisticated assay.
Can we thank Dr. Dogan again for a great talk?